Thanks for the introduction there, Dr. Gleave. So as he mentioned, John Suderman, PGY5 resident here at UBC, and I'll be chatting today on testicular seminomas. So a quick overview of my presentation. I'll introduce seminomas and we'll quickly go through some of the epidemiology and clinical details of the disease. We'll then discuss the management of both localized and advanced disease, incorporating some of the novel treatment pathways which have been recently studied, along with some promising novel biomarkers used in the clinical decision-making space. So what defines a seminoma? Germ cells in males are essentially just cells that eventually turn into sperm. Testicular germ cell tumors generally develop from precursor lesions called germ cell neoplasia in situ, and these precursors have been shown to develop from arrested primordial germ cells or gonocytes, which have failed to differentiate into pre-spermatogonia. These transformed primordial germ cells are thought to lay dormant until after puberty, at which time they are stimulated by increased testosterone levels and they begin proliferating. So germ cell tumors account for more than 90% of testicular cancers. Seminoma is the largest category amongst germ cell tumors, accounting for about 60% of all germ cell-derived testicular cancers. Siegel in 2021 published some epidemiological stats out of the US, and each year about 10,000 cases or just less than 10,000 cases of testicular cancer are diagnosed. Most patients with seminoma present with tumors localized to the testicle, but up to a third of patients have advanced disease at diagnosis. So when a testicular mass is discovered, a standardized set of evaluations should be completed. These, of course, include history, physical exam, along with assessment for risk factors, including inguinal surgeries, cryptorchidism, personal and family history of GU malignancies. Scrotal ultrasound should be used to characterize the testicular mass and also to identify any subclinical findings on the contralateral side. For complete initial staging, serum tumor markers, including beta, AFP, and LDH, should be drawn at diagnosis and also after orchiectomy. Hormonal and fertility evaluations may be considered. You should generally offer counseling on fertility preservation and also testicular prosthesis prior to treatment. LH, FSH, and testosterone are listed in some guidelines to be ordered, but I think it's rare that we actually order them, especially in the setting of a normal contralateral testicle, but certainly something to consider nonetheless. Finally, patients should be staged with either CT or MRI of the abdomen and pelvis. Brain imaging should be ordered if there's a concern for choriocarcinoma, including excessively high beta levels, extensive mets to the lungs or other viscera, or neurological symptoms. So as we know, presence of an elevated AFP excludes the diagnosis of seminoma. An elevated beta is noted in between 10 to 30% of seminoma, and LDH is usually reflective of the disease burden if indeed it is elevated. More recently, small non-coding microRNAs, which are involved in epigenetic regulation of gene translation, are being evaluated as novel biomarkers for testicular germ cell tumors. The early results for these seem quite promising, especially for seminoma, given the low rate of elevation of conventional markers. I'll get back to microRNAs later in my talk. Half-lives of serum tumor markers are, of course, important. Sufficient time should be given for markers to normalize post-orchiectomy before assigning an S stage. Usually markers are again taken 4 to 6 weeks after orchiectomy, and that should provide sufficient time for at least the trend towards normalization. As in any cancer, all patients should be staged according to the TNM staging, and in the case of testicular cancer, S staging as well. Recent T staging updates have started to include some histological features, not just in testicular cancer, but in some others as well, like penile. Presence of lymphovascular invasion can define a PT2 tumor even with a tumor localized to the testicle. Another notable difference for seminoma prognostication is differentiating PT1A and B lesions. There's now a size criteria of greater than or less than 3 centimeters of the primary tumor according to the AJCC 8th edition. So as an aside, a study published earlier this year makes a case for splitting all germ cell tumors, including non-seminomas, into T1A and T1B. In the 2024 publication, Lee showed a prognostic differentiation based on a size cutoff of 3.4 centimeters for non-seminomas. The top image shows the overall survival comparison in the cohort of 6,600 patients. The bottom shows the cancer-specific survival. They suggest that for any T1 testicular cancer, a tumor size of 3.4 centimeters should be used as a size threshold to differentiate the prognosis. I will, however, draw your attention to the significant stretch on the y-axis on these graphs, which of course limits the practicality as there's not actually that much practical separation. So moving on to end staging, size criteria for what defines a suspicious node has been defined using conventional CT. Hilton back in the 90s reported a high sensitivity of 93% and a modest specificity of 58%, using a cutoff of 4 millimeters for lymph nodes in the primary retroperitoneal landing zones. Based on this, retroperitoneal lymph nodes between 5 and 9 centimeters should be considered suspicious, and then obviously anything above that as well. FDG PET scans have been investigated for the initial staging of seminoma. They are not currently recommended for primary staging due to cost, radiation exposure, and a risk of false positives. Several small pilot studies dating back to the 90s initially suggested that FDG PET can identify retroperitoneal METs in low-stage seminoma and non-seminomas more precisely than CT. However, Huddart performed a prospective trial including 111 patients with clinical stage 1 non-seminoma on surveillance, where relapse was observed in 33 of 87 patients who were actually PET negative. The authors concluded that FDG PET is not sufficiently sensitive to accurately staged germ cell tumors, so that's why it's not used in initial staging today. For sake of completeness, I'll show the definitions of N and S stages for germ cell tumors. Nodal staging is split between N1, N2, and N3, where N1 is defined as nodal mass less than 2 centimeters, N2 is between 2 and 5 centimeters, and N3 has lymph node METs greater than 5 centimeters in greatest dimension. Similarly, S staging is split between S1, S2, and S3. Where individual AFP, beta, and LDH cutoffs exists. As the R5s were told at the McGill Oncology course earlier this year, you can memorize these numbers the night before the exam and then forget them the next day, but they're here for posterity. So testicular cancer treatment algorithms ultimately come down to the clinical staging. As an overview, clinical stage 1 disease is localized disease with no radiographic evidence of nodal or distant METs. Stage 2 is stratified based on nodal metastatic burden. And stage 3 is a tad bit more complex, but is more or less defined by distant METs and serum tumor markers. Historically, with clinical stage 1 seminoma, patients were treated with adjuvant radiation. Since 2004, the NCCN, AUA, and EAU, their guidelines have all changed, recommending post-orchiectomy surveillance as the preferred pathway rather than adjuvant chemo or radiation. This was motivated by our greater understanding of the long-term toxicities associated with adjuvant therapy. Since then, surveillance in the US has increased from approximately 40% back in 2004 to 87% in 2016, seen in the blue line in the figure. Among all patients with clinical stage 1 seminoma managed with surveillance, approximately 15% end up with disease relapse. So in assessing who is at highest risk of relapse on surveillance, two factors have been identified, including retina-testis invasion and also tumor size greater than 4 centimeters. Meta-analyses show that patients with both risk factors have about a 32% risk of relapse, and those with neither have about a 6% risk of relapse. You would think that this may push those with risk factors towards adjuvant therapy. However, a systematic review in 2018 showed that the prognostic power of both tumor size and retina-testis invasion is too weak to justify their routine use in clinical practice. At the end of the day, 5-year recurrence-free survival in all series was greater than 73%, even with retina-testis invasion or tumor size greater than 4 centimeters, meaning that the vast majority of the patients who are cured by orchiectomy alone and will not relapse. This suggests that adjuvant treatment, even with associated risk factors, provides marginal recurrence benefit and results in a large proportion of overtreatment. Further to the point, this is a nice table from the CUA guidelines showing that regardless of adjuvant treatment method, the cancer-specific survival remains very high, which ultimately justifies the recommendation of surveillance. So how do we proceed with surveillance? Surveillance recommendations vary quite significantly according to each major guideline for clinical stage 1 seminoma. Specifically, the need for both serum tumor markers and post-op chest X-ray have been debated, although with, so they've been debated along with the need for surveillance beyond 5 years. Starting with markers, the AUA recommends serum tumor markers as indicated, while the NCCN lists them as optional. The EAU guideline suggests serum tumor markers twice in each of the first 3 years of surveillance and annually in years 4 and 5. These recommendations are based on the rarity of relapse detected by serum markers alone in the absence of disease detected radiographically. So Vesperi evaluated the utility of serum tumor markers to detect relapse. Data was collected from a prospectively maintained database of patients on surveillance for stage 1 testicular seminoma. 527 patients were managed by surveillance and 75 relapsed at a median follow-up of 6 years. Of the 75 relapses, only 11 had abnormal tumor markers at the time of relapse, and only 1 had elevated markers with an elevated LDH before relapse was detected radiographically. The authors concluded that serum tumor marker levels did not aid in the early diagnosis of disease relapse for this patient set. Similarly, none of these guidelines strongly recommend chest X-rays as part of routine surveillance, though the NCCN guidelines recommends them as clinically indicated. A few retrospective studies have shown that virtually no relapses are detected by chest X-rays alone, limiting their utility, especially in the absence of positive markers or positive cross-sectional imaging. De la Peña retrospectively looked at a series of 1,400 patients with clinical stage 1 disease between 2003 and 2015. 159 relapses were identified, and every single relapse was detected by either rising serum tumor markers or a planned follow-up CT scan. Not a single relapse was identified on chest X-ray. They concluded that chest X-ray no longer has any value in routine surveillance of stage 1 seminoma and should be removed from the follow-up guidelines. Benefits of eliminating chest X-ray from surveillance would include reducing radiation burden, patient anxiety, and ultimately saving costs to the system. So what about cross-sectional imaging? Decreasing radiation exposure is always considered a goal of long-term surveillance. The trial of imaging and surveillance in seminoma testis, or the TRIST trial, looked at whether MRI or a reduced scan schedule could be used without an unacceptable increase in relapses. 660 patients were randomized, and they found that MRI was statistically non-inferior to CT, and that a three-scan schedule, at 6, 18, and 36 months was non-inferior to a 7-scan schedule at 6, 12, 18, 24, 36, 48, and 60 months. Although statistically non-inferior, more events did occur with the 3-scan regimen versus the 7-scan regimen, with a 2.5% absolute increase. These results, however, have yet to make their way into clinical guidelines. Regarding surveillance duration, the median time to relapse in patients on surveillance is about 1.4 years, and about 70% will relapse within the first 2 years. Relapses after 5 years are considered very late relapses, and these only occur in about 1 to 4% of patients and are usually detected due to symptoms like back or abdominal pain. Approximately 50% of very late relapses have elevated serum tumor markers at representation. At this time, it's unclear if surveillance beyond 5 years would have actually detected recurrences prior to patients becoming symptomatic. For those who do experience late or very late relapse, long-term disease-specific survival after treatment remains excellent, with greater than 90% 10-year overall survival. So here in BC, the BCCA recommendations state that patients with high-risk features, including those with tumor size greater than 4 centimeters or reticestis invasion, should be offered surveillance. They do, however, note that the exceptional patient is not available or unwilling to undergo prolonged and close follow-up, and they may be more suitable for active adjuvant therapy. So moving on from clinical stage 1 disease, we'll now discuss advanced seminoma. So if you're diagnosed with an advanced germ cell tumor, you should be assigned an IGCCCG risk classification, which guides treatment, prognosis, and follow-up. Advanced seminoma generally has a better prognosis compared to non-seminomas and carries a good risk designation in 90% of patients. The remaining 10% are deemed intermediate risk, based only on the presence of non-pulmonary visceral mets. Advanced seminomas are never designated as poor risk. So currently, serum tumor markers don't change IGCCCG risk status. LDH thresholds, however, have recently been proposed as a better way to stratify good risk patients. Bayer published on a data set of 2,400 men with metastatic seminoma treated with cisplatin and etoposide-based chemo between 1990 and 2013. Good prognosis patients with LDH above 2.5 times the upper limit of normal had worse 3-year progression-free survival and overall survival compared to the group with lower LDH. Now you can see in the images progression-free survival on the left and overall survival on the right, where you can see some prognostic separation when stratifying good risk patients based on this LDH threshold. So patients with regional lymph node involvement can be treated with either radiation or chemotherapy. Historically, radiotherapy has been the primary treatment for clinical stage 2A disease with lymph node mass less than 2 centimeters, and clinical stage 2B seminomas with lymph node mass between 2 and 5 centimeters, with an associated relapse rate somewhere between 9 and 24%. Chemo is also now a standard option, with relapse rates a bit lower at 0 to 8% for stage 2A disease and 8 to 14% for stage 2B disease. The role of primary RPLND in treating clinical stage 2 seminoma continues to expand, again with the goal of decreasing long-term toxicities associated with both chemo and radiation. So given the options, what should we choose? We know that seminomas are generally radiosensitive, which is why radiation was historically so heavily relied upon. However, patients who relapse after radiation require chemo, and having both exposures triples the risk of secondary malignancies compared to chemo alone. Patients with clinical stage 2B or bulky retroperitoneal nodal disease should be treated with primary chemo. Options include 4 cycles of cisplatin and etoposide, or 3 cycles of bleo, etoposide, and cisplatin. Bleo toxicities specifically include pneumonitis, cardiovascular toxicity, and Raynaud's phenomenon. Avoiding bleo is likely preferable in older patients, those with reduced kidney function, and those with lung disease. Regarding RPLND, complications are familiar amongst a group of urologists. Surgical morbidity cannot be ignored, certainly, with common complications including chyloscytes and anejaculation. So recently, the issue of excess mortality associated with chemo and radiation has been recognized. 5,700 men were analyzed in a Norwegian cohort, and those diagnosed with testicular cancer between 1980 and 2009. The authors identified that non-testis cancer secondary malignancies was significant, showing an overall standardized mortality ratio of 1.5. Specifically, there are increased risks of standardized mortality after both platinum-based chemo and radiotherapy. Interestingly, non-cancer-related mortality also increased by 15% with either form of adjuvant therapy. You can see in the image that non-testis cancer mortality was highest in the chemo plus radiation group and the lowest in the surgery alone group. So for this reason, primary RPLND has been proposed and initially investigated in the treatment of clinical stage 2A and B disease. As far as I'm aware, there are 2 concurrent single-arm trials in the US and Germany exploring progression and recurrence-free survival after primary RPLND. The SEMS trial, which is surgery in metastatic seminoma, is a prospective multi-center phase 2 study out of California that aims to evaluate the efficacy of RPLND in treating early metastatic seminoma at 12 sites in the US and Canada. As you can see, there are a couple of familiar names who contributed to the trial. In this study, patients who had isolated retroperitoneal adenopathy defined as either 1 or 2 nodes, 1 to 3 centimeters in size, were treated with open RPLND. The primary outcome was 2-year recurrence-free survival. So results of the trial were published in 2023. With a median follow-up of 33 months, 12 patients experienced recurrence with an associated 2-year recurrence-free survival of 81%. Of the patients who experienced recurrence, 10 were treated with chemo and 2 underwent additional surgery. At last follow-up, all patients who experienced a recurrence were disease-free, and the 2-year overall survival was 100%. Adverse events were rare, with 4 patients experiencing short-term complications and 4 patients experiencing long-term complications, including 1 with an incisional hernia and 3 with anejaculation. There was a trend towards recurrence risk association with nodal stage. However, this was not statistically significant, though the trend can be seen in the image. So how do these results stack up against the other standards of care? 5-year recurrence-free survival for stage 2A and 2B seminoma treated with radiotherapy is somewhere between 70 and 95%. The 5-year recurrence-free survival after cisplatin-based chemo ranges from 87 to 100%. And RPLND in the SEMS cohort had a 2-year recurrence-free survival of 81%, which is generally in the same ballpark, although the time frame is a little bit different. We know that seminoma patients generally respond well to salvage treatments, which makes these early results quite exceptional, especially considering that if all 55 patients in the SEMS cohort proceeded directly to chemo, 165 cycles of chemo would have been given, compared to only 33 cycles required in the study population after recurrence. Effectively, this represents a reduction of 80% of the chemotherapy given to achieve a similar result in recurrence-free survival. Looking a bit further into the details of the SEMS trial, minimum recommendations for the trial included RPLND that was a nerve-sparing modified ipsilateral template dissection, although surgeons were allowed to use whatever template they felt was best, including 35% of the patients actually undergoing a full bilateral dissection. 5 of the 12 recurrences were in-field within the retroperitoneum, with the others being retroperitoneal out of field and within the pelvis, peritoneum, and mediastinum. Although the SEMS study did not find that a bilateral dissection was associated with lower recurrence risk, the recurrence patterns might argue for bilateral RPLND. From a natural history point of view, seminoma is known to spread in a more predictable lymphatic pattern when compared to non-seminoma, which may further support the rationale for primary RPLND in a node-positive seminoma. So, of course, primary RPLND is a globally accepted approach in managing stage 2 non-seminoma. Series from Indiana and Princess Margaret show long-term non-seminoma recurrence-free survival somewhere between 73 and 80%. Given pure seminoma has a better baseline prognosis compared to non-seminoma, I think it begs the question, why do we use more toxic treatments for node-positive disease? I think radiation has been ingrained in the dogma of the disease historically. Seminomas responded well to radiation, and it was easy to give, and therefore we just gave it. I think the idea of primary RPLND is gaining some traction, though it has not yet been incorporated into guidelines. The one remaining question is how much data do we actually need to prove primary RPLND is a safe and viable option? I'll leave that question a little bit open-ended for now, as I'm not sitting on any of the guideline panels, but I think the results of the SEMS, and there's another one, the German study was the PRIME test trial. These results seem promising and have the potential to improve both quality of life and potentially survival for clinical stage 2 seminoma patients. So apart from primary RPLND, the idea of de-escalating systemic treatments has been proposed to cut down on toxicity. The SAC 0110 trial looked at de-escalating therapy for node-positive seminoma. So rather than standard dose chemo, single dose carboplatin, and then node-directed radiation was given. The preliminary results of 116 patients were presented. Their primary outcome was 3-year progression-free survival and was found to be almost 94%. 7 patients recurred and all were outside the radiated regions. Recurrences were subsequently treated successfully with standard chemotherapy. Long-term data for this are not yet available, but this may be another alternative pathway to decrease toxicity delivered to patients. Despite not being a useful tumor in primary staging, FDG PET can play a role in detecting post-chemo residual disease. This is the one and only indication for FDG PET in testis cancer. Among patients with normal serum tumor markers, masses less than 3 centimeters can be safely observed, given a mere 3% chance of viable disease being found in these lesions. The risk of viable seminoma increases to 27% in lesions greater than 3 centimeters, and this is where FDG PET is recommended. False positives occur secondary to post-chemo necrosis, desmoplastic or inflammatory reactions. PET imaging should therefore be completed about 6 to 8 weeks after chemo has actually finished. FDG PET has a high negative predictive value, but a modest positive predictive value. Functionally, this is great for ruling out active disease, but isn't great in determining when we should actually pursue further treatment. With equivocal PET, the scan can either be repeated or biopsy can be considered, though biopsy is generally unreliable due to the heterogeneity of a post-chemo tumor. If FDG PET is clearly positive, RPLND may be indicated. So at the beginning of the presentation, I alluded to microRNAs and the increasing interest in their usefulness as biomarkers. So microRNAs are small non-coding RNAs that are involved in the epigenetic regulation of gene expression and are generally dysregulated in cancer. We know that only 50% of all germ cell tumors express one of the three classic tumor markers, and we also know that seminomas lack AFP expression entirely. This provides some rationale as to why microRNAs may be useful as a biomarker in germ cell tumors. Serum levels of microRNAs for germ cell tumors were first investigated back in 2011, and seminomas were found to express microRNA 371 or M371 in more than 85% of patients. As a biomarker, preliminary results showed better sensitivity for M371 compared to traditional markers. In patients presenting with advanced disease, it has been found to correlate with IgCCCG risk classification. Serum levels seem to be associated with both clinical stage and tumor bulk, with levels dropping to normal with a half-life of less than 24 hours after the cancer is cured. The figure shows M371's dynamics seen as triangles compared to AFP, which are the circles, from diagnosis through treatment of an advanced non-seminoma. The black arrows show the 6 chemotherapy courses, and the red arrow shows surgical excision of the primary. You can see that M371 drops to 0, whereas AFP remains detectable. So Diekman examined serum levels of M371 in 600 patients with testicular germ cell tumors against 260 controls. Of the 600, 359 patients had pure seminoma, and microRNA levels were compared to beta, AFP, and LDH. For the primary diagnosis of a germ cell tumor, M371 had a sensitivity of 90%, specificity of 94%, and a positive predictive value of 97%. Traditional markers had sensitivities of less than 50% in seminoma. Notably, teratoma did not express M371, which is a major limitation in the applicability to non-seminomatous germ cell tumors. MicroRNA levels were again significantly associated with clinical stage, primary tumor size, and response to treatment. You can see in the figure the superior sensitivity of M371 on the right in seminomas compared to classic serum tumor markers. So tracking treatment response in advanced disease is another potentially useful application for microRNAs. Stepwise reductions in microRNA levels have been seen after iterative cycles of chemo. Turbuck published on 4 patients with pure seminoma who relapsed after first-line chemo. MicroRNA were measured 10 times higher at the time of relapse compared to when the patient was NED. You can see that in the results on the left. You can see on the right M371 serum levels in red with a seminoma patient at initial diagnosis of stage 3A disease. At the time of relapse, which was for this patient lymph node metastases, during salvage chemo, and then at 6-month follow-up with no evidence of disease after chemotherapy. So in comparison to the microRNA, beta-HCG levels spiked during salvage treatment, probably due to the destruction of cancer cells during the chemotherapy. But this, however, makes beta unusable when tracking disease response during chemo. Another related paper was recently published about a month ago in November of 2024. The Swenoteca MIR study assessed M371's ability to predict the response or the presence of viable residual tumor in metastatic germ cell tumor patients who underwent RPLND. 114 patients, 28 of which were pure seminomas, underwent either primary RPLND or post-chemo RPLND in the presence of residual masses. Pre- and post-op microRNA levels were compared. Among the seminoma patients, microRNA 371 had a sensitivity of 74%, specificity of 100%, and positive predictive value of 100%. However, the negative predictive value was only 21% for viable tumor. The levels of microRNA 371 significantly and rapidly decreased after surgery, which is seen in the violin plot here on the slide. This is especially useful given FDG PET's high sensitivity. So between the two investigations, we may now have access to diagnostics with both a high sensitivity and a high specificity for residual disease in seminoma patients. And this would help us better inform which patients should be observed and which patients should actually proceed to active management. So given these promising results, investigation into microRNA 371 has accelerated. SWOG 1823 is currently accruing with the primary objective to define the operating characteristics of microRNA 371 expression at the time of clinical relapse for low and moderate risk non-seminoma patients on active surveillance. As of January 2023, the study enrolled 657 patients. Interim analysis is planned for 40 patients, when 40 patients have relapsed, and results of this are not yet reported as far as I can tell. So rounding out our disease states, relapse after first-line treatment are rare in seminoma. Post-chemo relapse was standardized by the IPFSG. They looked at prognostic factors in post-first-line relapse and assessed treatment efficacy. In their analysis, 1,600 germ cell tumor patients were pooled from 38 centers. Pure seminoma represents about 13% of the cohort. Factors predictive of 2-year progression-free survival were identified, and these included histology type, seminoma versus non-seminoma, primary site of disease, gonadal versus extragonadal, progression-free interval, initial response to treatment, AFP and beta-HCG levels, and presence or absence of liver, bone, or brain metastases. IPFSG scoring risk stratifies these patients from very low risk to very high risk. Post hoc analysis of patients with seminoma showed 2-year progression-free survival of 75% in very low risk patients, and about 26% among those in the high risk category. Still, no conclusive randomized data shows which salvage treatment has the best survival outcome for a given prognostic group. Lorch published a retrospective review showing initial salvage with high-dose chemo plus autologous stem cell transplant may be superior to conventional dose chemo across all IPFSG prognostic groups, except in patients with low-risk disease. And you can see in the figure, there's good separation between all curves except for the low-risk group in the top right. The CUA guidelines therefore acknowledge the lack of solid prospective data and recommend either conventional dose or high-dose chemotherapy plus stem cell transplant for very low or low-risk groups. However, for all of the risk categories, high-dose chemo plus stem cell transplant is preferred. From a urologist perspective, FDG-avid residual tumor can be treated with either RPLND or salvage chemo. Decisions are usually dependent, at least in part, on how difficult the surgery is expected to be, as the desmoplastic reaction post-chemotherapy for seminoma is significant and can make those surgeries quite challenging. Ultimately, choice of salvage treatment in these patients remains controversial. So finally, as with any cancer in today's era, seminoma genomics may play a role in disease management. In a cohort of 133 patients with germ cell tumors, 3 somatic mutations were found to be significant, including the KIT, KRAS, and NRAS mutations. These are almost exclusively seen in seminoma and more so in patients with a history of cryptorchidism. Seminomas may be further differentiated by KIT mutation status, as tumors lacking KIT mutations can further differentiate into other non-seminomatous histological subtypes. Tumor sequencing may identify both progression and treatment response among patients with advanced disease. TP53 and MDM2 alterations were found to be associated with cisplatin resistance in a cohort of 180 patients, 30% of whom had pure seminoma. Begrodia was able to identify that TP53 alterations were present exclusively in patients with cisplatin resistance. That paper also shows that progression-free survival by P53 MDM2 status and showed improved progression-free survival for patients with wild-type germ cell tumor. That's seen in the blue line in the image there. So high-dose chemo plus stem cell transplant may overcome cisplatin resistance, which likely suggests that genomic profiling is crucial to identify those who should receive conventional dose versus high-dose chemotherapy in patients with advanced testicular cancer. So that's all I have. And in conclusion, there's a lot going on in the realm of testicular seminoma. From primary RPLND to microRNAs and also the genomics that I was just talking about. Special thanks to Dr. Black for reviewing my slides before the presentation today. And with that, I will open up the floor for questions and discussion.